anybody on the panel want to talk about how they've seen that, their own experience in terms of how these patients are presenting in your clinics?
So there are, in my clinics at least, there are definitely more patients who are metastatic, de novo metastatic, which has implications as we're choosing therapy in the metastatic CSPC setting. I don't know that we really got into it in our CSPC conversation, but de novo metastatic disease may be a population of patients who benefit from chemotherapy up front, not necessarily more so than AR-directed therapies, but more so than patients who are recurrent metastatic after localized therapy. So that's something that I'm seeing more of for sure because of changes in PSA screening that is going to have downstream effects in the metastatic CRPC setting. Because if I've used chemotherapy in the upfront setting, then I certainly can use cabazitaxel in the metastatic CRPC setting, but I also have the option of using one of the different androgen receptor directed therapies. And I think we all, I'm sure, do this, as we're thinking about choosing therapies in the mCRPC setting, we're always thinking back, what did they have before? Whether it's the non-metastatic CRPC setting, whether it's the metastatic hormone-sensitive setting, or CSPC setting, because I always think about changing mechanism of action. That's what we need to do. That's what we find is most effective. Not necessarily chemotherapy to chemotherapy, but particularly with the AR-directed therapies. And we're fortunate to have multiple approaches available to us, but I'm not sure what all of you think, but changing mechanism of action and not sequencing AR therapy after AR therapy is a key tenet to the way I think through things, the way I talk to patients, and something I try to avoid.
So that's a really good point, and I think a lot of times the data that I've seen is there's a lot of AR sequencing that goes on, and possibly it's going on for a whole host of reasons. Maybe it just seems that it's convenient. It's exchanging one oral therapy for another oral therapy. And we're going to talk more about that, but so let's kind of get into some more granularity of it. So Pedro, you have a patient who comes in, they've been treated with ADT and 6 cycles of docetaxel for hormone-sensitive metastatic, call it high volume, bone and soft tissue, and now they present to your clinic with mCRPC. What kind of goes through your thought process in offering additional therapy?
So it's a loaded question. So thank you for that. So I would have genomic information, which we can discuss a little bit about that.
No, that's great.
So up front, so I like to try to be ahead of the game, right? Mm-hmm. And so knowing what we have as standard of care, plus what else can I do outside the box, if you will, right? So for just a side note on the genetic information. So all patients with advanced prostate cancer should get germline testing, right? And it's now in the guidelines. And the reason for that, we're not only because we can impact, it has therapeutic implications for this patient, which we'll go there in a second, but also it can impact how we found a family, hereditary syndromes, and we can actually address and make a huge impact in the family for prostate or other cancers. So we can do that, and the sooner we do it, better, because we have time to do it. We don't need to rush finding, their parents or siblings or children, right? So that's one part of the story, the germline. For the patient that is in front of me, the question is, for some targets that are trying to emerge as great targets for therapies out there. And I'm thinking, obviously, the homologous recombination repairs. I'm thinking about microsatellite instability, and a little bit less, but also relevant, perhaps the PTEN, PIK, AKT's pathway, if you will. So those are factors that are relevant for us to know. And I know we'll talk a little bit about the therapeutic implications of those targets. And on top of the germline testing, also think about somatic testing, whether it's in the tumor tissue, or in circulating tumor DNA. The caveat of tumor tissue is, oftentimes in prostate, as we'll refer to, 90% will have disease in the bone, and about 50% or so in the nodes, and 20-ish% visceral disease. So it is a problem for us in terms of doing biopsies, getting access to tissue in the context of metastatic disease, and not a tissue that is archival tissue that is there from a radical prostatectomy that happened 4 or 5 years or 10 years ago, right? And so a lot of us are using or pushing a little bit for circulating tumor DNA assays, NGS assays on circulating tumor DNA, because we don't have access to the tissue the same way we do for other cancers. But that somatic information gives us more value than having just the germline information.